Good morning, good afternoon, everyone. Thanks for joining the second seminar of the year organized by the International Brain Injury Association and the Special Interest Group on Disorder of Consciousness. I take also this opportunity to thank all the support that we receive from the IBIA to organize and host these webinars. So it's a pleasure for me to introduce Dr. Professor Simona Ferioli for this IBIA DocSIG webinar. So Simona Ferioli is a neurologist and a neurointensivist, as well as an associate professor at the University of Cincinnati College of Medicine and the medical director of the University Neuroscience Intensive Care Unit, where her clinical and academic efforts focus on neurocritical care. In this context, she leads the neurorecovery effort for brain-injured patients with prolonged disorder of consciousness and has been collaborating with the IBIA DocSIG for many, many years now. So she's at the initiative of the Disorder of Consciousness Program project that created an international live map of centers for patients with prolonged disorder of consciousness, which was launched in 2022 with the involvement and help of many IBIA DocSIG members. Some of them I see are in the audience. So the result of the project first phase was recently published in the journal Brain Injury, with the objective to identify and characterize centers worldwide admitting care and caring for patients with prolonged disorder of consciousness and create a publicly accessible international live map. And today, Dr. Ferioli will present this project in more details, the result of the first phase, as well as the objective for the next phases. So the presentation can be interactive, so feel free to raise your hand if you have any questions for Dr. Ferioli while she's presenting. She can answer them directly, or you can also write your questions in the chat and we will read them after the presentation. But please, in the meantime, make sure to turn off your mic. So now I will leave the floor to Dr. Ferioli. So Simona, the floor is yours. Thank you.
Thank you, Aurora. Thank you, everyone. And thank you for the opportunity. Thank you, IBIA, to giving this platform to present this, what we have called small but mighty project. I have no disclosure for you today, and our objective will be simple. I will start with a brief introduction to something you probably know really well, which is what is the DOC program, probably from a perspective of the acute care provider like I am, and telling you a little bit of why we got to this journey that led to the MAP project, and then present the results and talk about our future directions. So the first observation that I make is from really an acute care provider. I'm a neurologist and I'm a neurointensivist, which means that I take care of patients that have acute brain injuries and fairly sick. And I've been doing this for 10 years or more, actually. And the first observation is that we have evolved in the way we care minute by minute about our patient in terms of monitoring and interventions and attempts to prevent secondary injury more and more. And I hope that is one of our rooms gives you a picture more than my words of how intense care is the care provided in the first few days or first few weeks. And there's what I call paradox, and I teach my trainees all the time, between that intensity that is provided in a very small period of care with the intent of improving outcome, and that bigger phase of uncertain care that follows. And those there are the doors of my ICU, where I literally stopped and watched those patients leaving our ICU and thinking, we've done all of this with control blood pressure and brain temperature and microdialysis of the brain for 10, 15 days. But what's going to happen of all that neuroprotection that we try to provide? Who is going to support that? So that paradox, a lot of care very early on, and a lot of uncertainty from our perspective, what's going to happen after. On the other side, the other observation that this patient continue to, the number of these patients that leave our acute care settings with a disorder of consciousness, not awake enough, keep increasing. And I've seen this again through my experience due to advancement in care, not just in neuro, but also cardiac. And I'm probably stating the obvious here, but we have ECMO, we have TTM, we have a lot of intervention. We have early neurosurgery in diseases that where we were not providing care 20 years ago. Think about the ICH new interventions that leave these patients that save their lives, but leaves them with disorder of consciousness at discharge. And this little chart was just our experience. We monitored for a year and a half how many patients left our own ICU, just a neuro ICU, so patient primarily with brain injury, leaving alone patients from other ICU. And a third of patients that left our ICU were not responsive at discharge, at some form of DOC at discharge. So you see on 174 patients, again, this was a very simple observational study that we did with our patient. 54 were discharged with a tracheostomy, with the need of a feeding tube, and were not responsive at discharge. So this phenomenon, this patient exists, and I dare say will keep increasing in number due to the advancement of acute care. And I want to just make a parallel with something that was said by Dr. Plum, one of the father of disorder of consciousness definition and observation in the late 1970s, when he described this middle group of patient. You know, as I said, there are some patients that will wake up right away. They will not need us. There are some patients that unfortunately suffer catastrophic injuries that don't survive the acute care. But there is a middle group that deserve attention. And this was observed in the late 1970s from one of the fathers of our field, and it's resonate deeply with what we do this day too. As this observation grew in me, thankfully, the literature and the research on the field keep growing from both from a recognition of these states and a more science and technology to probe consciousness and investigate the states of recovery of the brain, and from a idea that these patients don't univocally do poorly, that there is some hope of rehab for this patient. And so refuting the idea of inevitable poor outcome, both from a diagnostic precision and from a treatment standpoint. The last 20 years, I've seen a plethora of studying saying it is possible, it is real, it is possible. And these, as you all know, end up, thankfully, in many scientific societies promoting guidelines and recommendation to support the diagnostic and the care of patients with disorder of consciousness. Again, as you see, both at national and also at international or level, from multiple groups, which really speaks to the experience that we all do on a day-to-day basis about the complexity and the opportunity that caring for these patients offer. And I took a screenshot of some of these recommendations just to say how rich they are and how detailed they go. You're not supposed to read necessarily this, but out of this very detailed and helpful recommendation to implement in practice, one thing that when they start coming out resonated from, again, my acute care perspective and experience was the 20 days. You all know that the definition of prolonged disorder of consciousness when it goes beyond 28 days, and that has been all over the literature. But as I looked at that recommendation, to wait until 20 days before using strong statement to suggest prognosis to allow patient to recover, from my standpoint, I start asking, so what happened during 28 days? Those patients are under my care for maybe 10, 12, 15, but rightly so, we should support them and not prognosticate too early, up to 28 days and more, as we know. So what happens? Who cares for those patients? How can we support those 28 days to really promote probing consciousness and promote rehabilitation when needed? And to answer that question, I have to say that the studies that I showed before, those recommendations, are really done well. And again, you probably know that literature, but I always invite my trainees to do a deep dive in this recommendation because they really come from experience and expertise and exposure. You know, we talk about RCTs, but reading through those guidelines is really impressive how they speak of the experience of the providers that actually got together and shared their common experience through their science, through their studies, as true expert practice. And the pillar of a DOC programs that are described are probably largely the same across the guidelines. And as you know, they deal with prognosis and diagnosis, make sure that we get it right. Because as I always say, we have in my clinical practice, we cannot get it wrong. We know a lot of people that have inevitable difficult outcome, but we cannot miss that person that actually will make it through. And that's our duty as acute care provider, not to prognosticate too soon on those patients. And then, of course, on treatment advancement that keep increasing in the literature, and then care planning and social ethical support. So these are the pillars that you know well of DOC programs. And I will just go quickly through them because I think I'm talking to the expert of the science, but I just want to again give a little bit of perspective of what to me are the crucial point of this care. And of course, the diagnostic and prognostic assessment. I think I'm speaking to some of the author of those scales that have been designed and studied and validated to really try to capture the complexity of consciousness improvement through rehab, and how important it is to mingle and intersect that type of assessment with actually the initial care that this patient received and the initial diagnosis. If I could just make a point, I just really appreciate how through the guidelines, for example, there is stressed the structural imaging data review as a starting point. When I start following patient with DOC, the team that I was rounding with always made fun of me because I couldn't enter a room without seeing the CAT scan or the last MRI. But just to integrate, attest the fact that DOC program really are integrated care and a continual care to be successful. And when it goes to the treatment and teams, again, what I discovered just start learning about DOC programs and DOC care is that not all neuro rehab is the same. We have many centers that rehab patients that have a neurological condition. But the idea of trying to rehab a DOC patient, it's really multidisciplinary in the sense that we need each other to understand that patient. Say multidisciplinary as probably something is very used in every discipline. Everything needs to be multidisciplinary. But I realized that a DOC patient needs the PTOT provider sometimes to start the presentation, or the family, because they have grasped something on their last assessment or in the night before that I didn't know through the chart, or I didn't know in my 5 minutes of visit. So it's multidisciplinary is paramount, probably not just from everybody at the same table, but just because there is a richness in the multidisciplinary evaluation of this patient that is essential for DOC care. And also the medical care, the importance of having medical care and specialists that is stressed in all these guidelines to avoid readmission and provide continuity of care. These patients are really sick sometimes and have complex polytrauma, complex medical issues, but in order to offer DOC care early on to promote that arousal of consciousness, having specialties available and connected, it's really essential to promote their care and is really stressed through DOC program. And of course, education of staff at all levels, right? Another thing that is easy to say, everybody should be educated, but just to offer an example of that, as I start taking care of this patient outside the ICU, we realized that DOC patients were best hosted in the same wing of the post-acute care, because the nurses would learn how to work with them in a different way compared to the other neurorehabilitation patient, that there was a way to care for a DOC patient that nurses could teach each other and was better to host them themselves, so that day-by-day education could continue among the providers specifically specialized in DOC care. Just a little example to speak of the importance of education and multidisciplinary team. Again, not just a slogan, but a true pillar of DOC care. And then, of course, treatment. Once again, you're probably all authors or highly expert of DOC treatment efforts and investigations. But again, there are so many factors that need to be stressed when it comes to treatment, from environmental factors to addressing the mobility. And I really have to say that from a acute care provider, I learned a lot from this group about the importance of mobility, Aurora being one of the author on the importance of increased tone and contraction in the care of this patient, because the paradigm is almost flipped, right? We have to move these patients to wake them up. We don't have to move them to restore their mobility, but as a tool to restore their consciousness. And on the other side, again, from my perspective, we do a lot of things that go against it, because all that neuromonitor, vigilance, and care that we do early on is predicated on very low mobility, because we have so many variables to monitor and treat, where mobility, even if we talked about early mobility in all acute care, is almost not is not a priority of the early care that we have to provide to protect them from secondary injury. So it's really a paradigm shift from the acute care for sure, but also how we intend mobility, not just as a regain function, but actually stimulate consciousness, as I said. And then, of course, the application of neuromodulation and pharmacotherapy, and how to monitor those therapeutic interventions. Again, another simple example that I'm probably speaking to the choir here, but we've learned how, for example, to time neurostimulation pharmacotherapy, like they approved amantadine, around time for therapy. You're probably saying, sure, you didn't know how to do that before. And yet, just having the family or the therapy session provide a feedback on whether or not those therapy provided increased wakefulness or promote arousal in this patient was key in the timing and planning of therapy and medication administration. Just to speak again to the complexity on how all this therapy and teams need to interact together to be a successful program and to be an effective program that can monitor results. And then the last piece that, of course, we all know, but the last and not least pillar of DOC programs is the care support for caregivers, and both from a financial support, but also community resources. We all know this is a life-changing event. We all know that it takes a village. We like to say that, but truly, it's a new village. It's a village that didn't exist before that brain injury. It's a village that needs to be educated and support to thrive. There is a lot of evidence that in the crucial point the caregiver have in the outcome of these patients, but they need support and resources. And this is the time. You know, another thing that I've learned through my experience is that we talk about giving resources to the caregiver early on. And I am sure that if I ask what each one of you will say that, then the caregiver, we are giving resources in acute setting. And a week later, we realized that none of that was registered, right? Because they were not or very little, because they were not in the emotional time to receive those information. The acute care setting is not always the best time to educate this patient. And this is why now, once you're outside that high stressful moment and families start realizing the ramification and implication of this event for their family, they need to be educated longitudinally, both on, again, ethical, legal, and economical stuff, on top, of course, the care, and become themselves caregiver, but support a caregiver. And also a word on the fact that if we said, rightly so, that the first 28 days are not the time to prognosticate and start talking long-term care, perhaps this is the time where palliative support and decision on long-term care needs to be implemented in a strong, continuous way so that resources such as palliative care or discussion on goals of care can happen, especially after the journey has been established and direction of the journey of the patient is a little more clear. And this is the time for those resources to be present and be effective. So again, last pillar, but probably one of the more crucial for the success of this program is the support to the caregivers, both from a economical, educational, and ethical legal support. All right, so the literature is there. I read it all. I was an enthusiastic DocSIG member when I first joined, like I think over around 10 years ago, 8 years ago. And I thought that that's what we needed. That's what my patient needed. That was out there. And again, reading those publications I briefly mentioned it's not just about trials, it's about expertise and experience. They really speaks volume of people that have been doing this for a long time and learned the value of providing this care and put it out there for the community. So my question, and truly the story goes this way, my question to some of the IBIA members through an email was DocSIG members, IBIA members, was so where are the centers? Where is the website? Can you send me the link? Where do I find a center for my patient? Where are you? And this is in this definition. There is in this slide I have the definition of DOC programs, but the definition is clear. The why and the what is clear, but the where was missing. And instead of the answer that I got, thankfully, was let's get to work. There is not such a list. It's not very clear where these centers are. We know what they are, but we don't really know where they are and who is doing what. Let's work on that. And we start working on that, as Aurora shared, by launching a survey through IBIA and other scientific societies involved in the care of these patients, asking some questions at the center level, trying to figure out who is doing what. And we wanted to put the information that we found and collected available for everybody, both caregivers and providers, because that question is both my question, but is also the question of the caregiver saying, where do we go next? Doctor, where do you advise us to go? And as you know, brain injury doesn't always happen next where you live. So the importance to have really a large range map to be able to counsel people that often have to go back to their to where they live, or go back to a caregiver that now becomes a caregiver that was not living close to where that person that was previously independent lived. And also the idea of keeping this project international, which I still think is one of the biggest advantages and again, source of richness for the program, because of that expertise is really spread across the world and can feed each other, can feed into each other as far as community building and opportunity for improvement in DOC Care Center. So we collected some answers, and once after a year or so, we decided to build this map that is available. And if technology supports me, I just want to make sure you can see it. So it's you can follow this link, and I believe it'll be in the chat later for you to find it. But it's in the IBIA website. So I'm gonna screen share and show you that after clicking that link, you arrive to the IBIA DocSIG page, and you can see the interactive map here by clicking. And please let me know if you don't see it. And then you can really navigate by where you live. So and see how these centers are represented. And now surprising was that we really got answer sparse across the world of people that identify themselves providing post-acute care or acute post-acute care for disorder of consciousness all over the world. And as of now, what you find by clicking is hopefully a website and a phone number to be able to reach those centers. So again, this is publicly available on the IBIA website. I hope you can see my screen. Great. So in the next few minutes, I will present you the results of what we found, hoping to give you a little more information about this project. And I want to keep your curiosity up because this project is not over yet. So as you see these results, if questions or suggestion on how we could have done this better, or question we could ask come to your mind, please share them, because there's more to come to this project. And this was my first attempt, supported by all the DocSIG members in doing something like this. And we learned a lot. I learned a lot from them, and I also learned a lot on how best design this type of project for the future, I hope. But these are the survey by country. You see, at this point, Europe and the United States were the most represented as far as geographical location, but we had a little bit of centers throughout the world, really. And when it comes from to Europe, Italy probably drove the majority of the results for their center, which I think is part due to the societal organization that some of these centers were able to reach locally, and it's something definitely to look up to. And I'm going to go through the questions that we asked. So the first question was the demographics, and then we asked which kind of diagnosis they admit. And I was surprised to see that diagnostic criteria are not a criteria of admission throughout the centers that we collected. 78% of centers said that they don't discriminate, if you wish, on admission diagnosis, but there was a subset, like about 20% of centers that do have an MCS minus and plus criteria. So they start with patients that are probably already recovering when it comes to DOC phases. When we ask about the age of the patients, I was also surprised to see that age was not a criteria for the majority of the centers. 77% of center did not indicate an age. And also, this slide was important to us to recognize the presence of pediatric-only DOC centers that have been listed in the guidelines. Guidelines have definitely reference to pediatric-only DOC and the unique features of this subset of the DOC population. But 6% of centers self-identify as center that take care of age 17 or younger. And that was, again, an unexpected result for me of this survey that requires more investigation and trying to figure out how we can best represent the population, the pediatric DOC, moving forward. The next question we asked was about international patient. Again, I'm probably from experience, but I really thought it was important to know who can do DOC outside where you are if you happen to be in a location that is far from your family when your brain injury occurs. And we had a mixed bag of results, but probably half of them said yes, but depend on a case-by-case basis, recognizing there are financial consideration when we deliver care outside our national system for some people. And this, the question about mechanically ventilated patient is definitely a question I learned from. The question here is trying to grasp, do you accept patients that are still weak or not awake enough to support their work of breathing, right, to protect their airways? Do you accept patients that might be weaning from ventilation, which, if you wish, is a question of acuity in some sense? And this was really telling to me that half of the center provide that kind of care, but half of the center start taking care of the DOC patient once that acute or post-acute phase of rehabilitation is over. And again, this speaks probably the different acuity that our program are able to support. This is another question about level of care, trying to identify where that acute to post-acute care transition falls. And this probably reflected the heterogeneity of our centers too, because we have results a little bit all over the place, where about a quarter of centers don't really have a criteria for acuity. Some centers define themselves as acute only, so they probably take care of only those first few weeks, and the other one add a mix of results. This question suffer from the limitation that the definition of acute or post-acute care of PDOC is very gray, right? We don't have a good way to establish that definition, and that's why probably some of the other questions we're trying to get to how sick those patients are, asking about mechanical ventilation. But there was, when we tried to make some comparison among geographical areas, we did notice that the acute care response was more present in the US respect to Europe. And I didn't present here the comparison with the other states or nations, just because they were not represented enough to make robust statistical representation. And as expected, the post-acute care expected from a model of care was probably more represented in the European and the Canadian centers. And I'm happy to take questions about these results later or now if you wish. I was actually surprised about this result too, because it's foreign to my practice, but at least 38% of the center among the 150 that answered this question said the 62% answered, so more than half of the center answered they provide some outpatient or day hospital care for DOC, probably speaking of that need for continuity of specialized care that this patient have once they leave the acute setting. And is a very interesting concept, again, that speaks on the fact that DOC care, it's more than neuro rehab care, if I can express it that way. Length of stay was, again, another important question, trying to figure out how long does this patient can be hosted in your center, which kind of longitudinal care it's available. And the majority actually picked a broad range. I was surprised by this answer too, where 53% of center indicated that their length of stay can be anywhere between 2 weeks and a full year. As you can imagine, when we run some comparison, this again, based probably on a model of care, national model care, health, public versus private, the shorter length of stay was less frequent in Europe, more than the United States, where length of stay has some financial implication on coverage in some cases. And then when we ask, so what determines length of care? This is where the answer were all over the place, and probably this question deserves some thinking on how best capture the possible answers, where functional progress was indicated by a lot of center. 20% of center put that as their primary criteria on how to determine when the patient is ready to move to the next phase of care. Some have national system regulation, and probably the majority, if you sum them together, add a mix of functional progress and other measures like insurance or national guidelines to guide this milestone, if you wish, on when the patient is ready to graduate or transition to a different level of care. And there were a lot of answers that actually, this was an open field question that actually dealt into is why our institutional protocol. So there was also local experience to dictate this factor. How is the referral was another question that has some differences across geographical areas. Most of the institutions said that is a mix of physician referral and transfer, but there was a signal toward physician referral and family outreach as criteria more in the United States, where European center, where it's probably a streamlined transfer from acute care. So probably speaking of a more collaboration of continuity of care or path already implemented, where it's not up to the physician referral, or it's not up to the family choose, but there is a pathway. And probably something to learn from that, because there could be some opportunity of continuity of care if there are procedure and placement to keep this care as streamlined as possible. And a lot of other have other combination of answers that all revolve around a combination of physician referrals and family outreach. And these are the final few questions, so bear with me. And these are simple questions we ask back to my spiel about the importance of training and experience. And I have to say that even the majority said that they do have some specialized training experience given the provider. At least 26% said no. We care of this patient, but we don't receive training specific for DOC. And that was slightly, that answer was slightly more present in the European center compared to the USA centers. When we ask about guidelines, the one we just review quickly, again, strong majority knows the guidelines and uses, but there was still a signal toward centers that care for DOC center, but could benefit from more guidelines implementation. And these are, when we ask about the guidelines, I just want to show briefly which kind were the guidelines that were, which guidelines, when we ask which guidelines do you actually follow, and most of them are the ones we just talked about, and some are actually more local national guidelines, or some mention actually society guidelines, smaller society guidelines, or even institutional guidelines that probably mirror the national one but adapted based on their resources. And then caregivers, thankfully, everybody knows and is aware that you cannot do DOC care without caregivers for multiple reasons I tried to allude before. And so caregivers are fundamental and involved in the strong majority of centers. But when we ask, like, what do you do with the caregivers, right? Back to the observation we were making before, there's still a fraction of centers that at least would like to do more education and more counseling. And these are resources that are hard to come by and hard to implement, but again, are probably key to the success of these centers. Other key pillar that I probably haven't mentioned, but I'm really glad that I was suggested to put this question in the survey when I first we first have our first draft, and we discussed it together with the DocSIG member about the association support group that can collaborate to foster that caregiver support and advocacy. And it's pretty interesting to say that there is opportunity to grow this presence. At least 1/3 don't have patient associations or patient advocacy from support groups present in their programs. All right, so those are the questions, and those are our results of this preliminary project. Our goal was the one to build an online tool for caregivers and providers to search for specialized prolonged DOC care across the world. I feel, again, I'm repeating myself strongly about the international nature of this project, and this little mighty project is online, available for everybody, and we are striving to update that map as more information come. And if you are one of those centers and you see that your information are not longer up to date, this was 2022 when the data were collected, please reach out to DocSIG, please reach out to me. We wanted to have those information as reliable as possible. And the idea was also, as we built this, I've frankly learned that this was probably not just a little tool for providers and caregiver, but it will and should probably become, has the potential to become, a preliminary census of facility to really assess the gap in clinical care for patients with DOC in specific geographic areas. This is high-end, if you wish, specialized care. Probably not every rehabilitation center needs a DOC center, but I would argue that any provider that deals with this type of brain injury patient that are left with the DOC needs a DOC center of reference that can collaborate and build care and protocol for advancement of care moving forward. And so really, if you wish, the future direction that came more evidence as that we were building this project are to not just provide a resource, which remains paramount objective, but also to increase the collaboration of growth of this international community to facilitate both the clinical and the research networking effort. This all started by me asking, where do I send my patient? And I'm really grateful on how it's grown to become a potential platform to foster collaboration among DOC centers as such. So please stay tuned. As I was referring early, I would welcome any feedback because we are planning based on what we realized the potentiality that this project have to relaunch the survey, learning from, for sure, from my mistake, how the survey can be fine-tuned and can capture better information. Also, more of the information that are more helpful to families and caregiver in terms of details on how to choose these centers. And we would like to relaunch the survey. So expect a letter in your email if you're one inbox. I mean, if you're one of the IBIA or DocSig member. And my humble request here is to please help us sharing this effort and initiative by spread the survey once the next version will come out, hopefully soon. We are planning to send it out in the next few months, probably early 2026 at this point, to really make that map as representative and as accurate as possible, both for us caregivers, for our patient, and also really to create a platform to support all the research and clinical investigation that are out there for DOC patients. And this is it. I welcome any question, any feedback, or any discussion. I'm sure there are a lot of passionate DOC care providers here. And I, again, thank you one more time for your attention and the opportunity that IBIA gave us to conduct this project and show it to you.
Thank you very, very much, Simona. I see a lot of people who already appreciated your presentation. It was wonderful, inspiring, and in general, thank you for all the effort and enthusiasm that you put in this very relevant project, of course, for healthcare professionals, patients, caregivers. As you mentioned, I think it's also a good way to gain visibility, really highlight the importance of providing appropriate care for patients with prolonged disorder of consciousness, and hopefully in the future, this will also help to improve the adherence to guidelines and promote also the care of patients with prolonged disorder of consciousness. And as you just mentioned at the very end of the presentation, that it will also foster collaboration among centers specialized in DOC. So yeah, I think it's a great project with a lot of promises. So thanks a lot for the presentation and all the work in general. I see that there are already a few questions in the chat. If you have questions, feel free to write them in the chat or raise your hand. We still have a few minutes, or more than 10 minutes for Simona to answer the question. So the first one is from Amandine Renier. So thank you for this really interesting presentation. I think the map will be very helpful. And the question is, on what basis do you define that a provider is trained? Is it based on specific types of experience, formal education, certification, or any other criteria?
That is a wonderful question, and actually something that I discover as something that was not well defined in the first version of the survey. I have to say there is a value in asking people, do you feel trained? You know, were you given the resources? Because actually, when you go through the guidelines, especially the recommendation on centers, there are tools available, and both online and through IBIA and through our scientific society to get specific DOC training. But to answer that question, there was not a clear definition on this survey, but we plan to change that a little bit in the future version. What actually in asking as an open question, which kind of training you have received. And I don't know if you probably have more experience being than I have on specific training. I know they are available. I know that I had some of our providers when I followed in post-acute care going through the training available through different societies, but it's still something that is not clearly defined or the same for everyone. I don't know, Aurora, do you have some
I
input
think
in
it
this.
will be a great addition to the next the second survey to know a bit more about what kind of training I mean, and if they think that this will be sufficient. So for sure, I think that will be a great addition to know more about what kind of training and what kind of training they would like to receive. If they feel comfortable with that, if it's just like a 1 point at the beginning or if it's a continuous training. Indeed. And yeah, and I cannot I can cannot not say that regarding the training, we will organize a CRSR online workshop very soon. If someone from the group can also maybe put the link to register on the chat, that would be great. So yeah, that's it.
Great feedback. I'm taking notes. So thank you for sharing that.
Then there is Priscilla Cassar saying extremely useful. Thank you. Is anyone in the audience wanting to ask questions to Dr.
I have a
Ferioli?
question.
Hello. Hi.
Hi. Thank you. Great presentation. My name is Janet Marini. I'm from Arkansas Children's Hospital, and we are starting a DOC program here. I'm curious how you would recommend classifying our patient population because we take patients in rehab up to 21 years of age. And so we wouldn't be under 17 or under only. So it technically wouldn't fall under that. I wouldn't know how to classify us. And then the second part to my question is we take acute all the way from PICU through progressive care. Sometimes these patients get admitted to rehab. We run into the problem of course, in the US, not tolerating 3 hours of therapy as a barrier with insurance. And so sometimes these patients are on a progressive rehab floor. They're not technically in rehab service. So then some of those questions about admitting these patients and length of stay, I was trying to think through how we would answer those questions. So I would love any insight into that.
I am gonna answer the age question because it relates to the survey, and but I also would love to phone a friend. I think I saw Brooke Mortag on on the chat, and I think she can speak more eloquently than I can to your second question, just which is very U.S. specific, and I struggle with that too because we are the opposite, right? We are an adult center, but patients don't say their age when they have their TBI or car accident, right? So we often end up with 16-year-old that looks like they're 25 or even younger ages, and their care is different. I think that the age of pediatric, it was hard to define. It was one of the things we discussed too. For the next iteration of the survey, we might just use pediatric versus adult, leaving that 17, 18, 20, 21 definition that could be a little variable. I think we all know that a 17-year-old or even a 21-year-old rehab very differently than a 76-year-old. And so just using using the term pediatric versus adult will help us categorizing what we mean, because we know what we mean better than having a strict cutoff. So for the future version, I think that's what the language will be used, and hopefully will be easier to identify yourself in one of those buckets or both if you're really doing both. I am fairly sure that the 3 hours rehab in the DOC literature has been, in practice, has been addressed, because what we mean by 3 hours of rehab in DOC might mean something different. But I was really curious if Brooke's any suggestion on that, because I am fairly sure she has done a lot of work. And I'm sorry if I called you out unexpectedly. If you cannot talk, I thoroughly apologize. But I also want to connect you with the expert if possible. And this is the beauty of DocSig. I am here because I'm learning from this group. I'm really more getting information in than being helpful. And again, especially from the acute care perspective, this is a huge opportunity for me. So Brooke, do you have any idea? Are you able to talk?
I'm in the car, so I won't turn my camera on. But as far as Janet sending this survey out round 2, getting it to your group, the goal of this, Matt, and knowing that at Arkansas Children you do have acute and post-acute, my recommendation would be that the goal of this map was to identify those post-acute centers. So answering the survey and the questions within that paradigm of your post-acute care services. Now, I could get on the soapbox about the American healthcare system and the 3-hour rule, and that's such such an arbitrary number that Medicare and Medicaid services just threw out there, and it stuck, and then all the other private insurance companies hooked onto that. But, you know, there's certain workarounds with that. It takes some advocacy, but I know in our experience, we're able to kind of work around that and get patients in who can't, quote unquote, actively participate in 3 hours of therapy, but we certainly can get 3+ hours of therapy done, because we all know there's so much to work on. I don't know if that helps answer your question, Janet.
And that is my experience too on the adult. Even if I'm not the provider, I think working with rehab specialists that understand DOC, the ability to participate is something that really needs to be interpreted with rigor, and knowing that participate means different things. You know, in the rehab, I don't know if I'm stating the obvious, but participation of an unresponsive patient means a different thing than participation of a patient that's broke a leg or something. But it's up to our expertise to translate that.
Yes, thank you guys both for that. We do our best to try and advocate for these patients to get onto rehab service, and sometimes, as far as our rehab service, it's part of that's where it's the gray area. It's acute, post-acute. So we don't get pre-authorization. We end up going for Medicaid denials and go to hearings because they decide not to pay. And so we make the decisions on the front end on what's best for the patient. And so still working with the team to recognize that what's best for the patient is being on rehab service. When they're on the progressive floor and not technically on rehab service, it's a technicality. And so we're still doing all the things, the specialized team, specialized care, rehab meetings, family education involvement, and all the things. It's a technical differentiation, and then how we would report that for studies like this. So that's definitely something we're kind of working out the kinks with. But yes, that's helpful. Thank you so much.
Thank you very much. I see a few more questions in the chat. So Ariana Sala is asking, is suggesting impressive and very useful work. Maybe I missed it, but do you have also the information or plan to get the information on the kind of neurophysiological assessments to each center, if each center collects like EEG, MRI, PET, FNIRS, etc.?
Yes, wonderful. I'm really glad that I think yes, I'm really glad you pointed out, because it was a question we didn't ask. Also, just to be more inclusive and making sure that centers didn't feel that I have to check all the dots. DOC care is done in setting and might not have all those tools, but also I think especially now with those technique being more and more available and studied and need to continue studying and collect results. Yes, we will ask that question in the new version of the survey, specifically delineating those techniques and whether or not centers can carry ability to do those. Also to figure out who actually can, because it might be still a very limited few that have those capability, and that will speak of the generalizability of those opportunities, both diagnostic and treatment. Great question. Yes, we missed it on the first version. We'll be sure to add it in 2026.
Thank you. And then there is also Priscilla Casa saying, was there any particular reason given for having no center catering for over 65 years old?
If I don't know if I'm understanding the question correctly. That might be partly my fault. From the United States perspective, that question was probably from a United States perspective. That question was trying to figure out if there was an age after which DOC center didn't think that there was potential for rehabilitation or potential for a good outcome. So if there was a limit cutoff for which people feel that DOC is no longer offered. DOC care is no longer offered. I hope I'm understanding the question. I don't know, Aurora, if you want to.
Simona, I think I can add to that too, because In the United States, the majority of individuals, if that was with the results of not a ton of centers catering to those over 65, I think it's more of a Medicare issue
Yes.
versus a recovery issue. Because if we were to take a patient whose primary payer source was Medicare A on our acute rehab service, we would be lucky to get 10, 14 days max. They'll pay us for that much. We can certainly keep them longer, but then we're doing it without a payer source. And so it gets really, really difficult to get as much in as we can in that truncated time, and get family trained. A lot of times caregivers are also older and maybe not able to provide the physical care. So it really is a limitation, but not because we don't think they're going to make progress. It's because we can't keep them for any significant period of time to make a significant change in burden of care or family training. I mean, even home accessibility at a wheelchair level or getting a hospital bed ordered would be, we can't get it done in 14 days. That's just my perspective, and I know the things that we talk about within our own center when we get referrals for acute rehab over the age of 65.
Absolutely. I think that question stemmed from that. And I have to say, from a purely survey methodology, that question also had any age as an answer. So there was also the possibility that people that still doesn't use that as a cutoff. I was just thinking that non-United States centers where there's still some of the things that Brooke mentioned apply, like age of the caregiver or even just self-fulfilling prophecies in the acute care. So not a lot of patients over 65 might reach that point where care might be withdrawn earlier from an age standpoint. I'm just putting assumption there. But there was the any category, so we have to revisit how the answers are made for the future. And this is another great observation that made me think of that, to make sure that those over 65 didn't actually got scored into the any as a possible answer, if that makes sense. That's purely survey methodology that I deeply learned since the first time I tried this.
All right. Thank you very much for the question. Thanks also for your input, Brooke. I see that it's this webinar is over. Do we have any pressing questions for Simona? Otherwise, you can always contact the SIG, the IBIA. If you are interested to put your center in the map, then you can also contact the IBIA, as well as Simona or us. So thank you again very much, Simona, for the wonderful presentation. I see that it raised a lot of interest, and I'm also very excited about the second phase, which will gather even more information that we could use to improve the care of patients with disorder of consciousness. So thank you very much, and thank you to all of you for being there and attending this webinar. So thank you very much.
Thank you all.
Thanks, everyone.